Ventricular fibrillation and asystole. We're going to define ventricular fibrillation and list the diagnostic criteria of this rhythm. We're going to discuss the mechanism behind the formation of ventricular fibrillation and why we use defibrillation to treat it. We're going to define asystole and list the diagnostic criteria of this clinical entity. Define agonal rhythm and list the diagnostic criteria of this rhythm. Identify VFib, agonal rhythm, and asystole on a rhythm strip or ECG, and explain the concept of pulseless electrical activity. And we're going to manage a cardiac arrest utilizing the American Heart Association Pulseless Arrest algorithm. So ventricular fibrillation is defined as a rapid, completely disorganized ventricular rhythm, and it is electrographically represented as undulations of varying shapes and sizes with no pattern and no discernible P, QRS, or T waves. VFib does not produce a palpable pulse. It is a fatal dysrhythmia, and it is one of the most frequent initial rhythm occurrences in sudden cardiac arrest. It tends to occur in the initial hours following an acute myocardial infarction, and it occurs as a result of multiple weak ectopic foci in the ventricles. This is what the fibrillating heart looks like. Myocardial cells appear to quiver rather than depolarize normally, and they're not strong enough. They don't create an axis strong enough to create a wave of depolarization in order to get a good contraction. There's no coordinated atrial or ventricular contraction, which equals no palpable pulse, and the electrical impulse is initiated by multiple ventricular sites, and impulses are not transmitted through the normal conduction pathway. There's a spectrum of possible presentations with ventricular fibrillation. You've got fine ventricular fibrillation because of its smaller amplitude, and sometimes it may be mistaken for asystole on the cardiac monitor. And you've got coarse ventricular fibrillation, which can be mimicked by artifact on the cardiac monitor. Always perform a careful assessment of your patient. In order to differentiate between fine VFib and asystole, switch the leads on your cardiac monitor. If you see the typical fibrillatory pattern, even if it is small, then defibrillation is indicated. VFib is made because you've got multiple ectopic sites that are creating their own electrical conduction, and you're not able to get a strong enough conduction across in order to get a good wave of depolarization. Chaotic depolarization of the ventricles leads to VFib. Defibrillation leads to a state where all the myocytes of the heart are depolarized instantaneously. This essentially resets all of the myocytes. The hope is that the normal cardiac pacemakers will then be able to take over pacing function, and that transmission of the depolarization wave can proceed normally through the reset electrical conduction system in myocardium. The single most important treatment for ventricular fibrillation is going to be defibrillation. Patient assessment is critical in that artifact or loose leads can resemble ventricular fibrillation. Treat the patient, not the monitor, but if the patient's symptoms match the monitor, aggressively treat it. And causes, most common cause is going to be acute AMI, myocardial ischemia, drug toxicity or overdose, hypoxia, and there are some other causes as well. So your answer is pretty much no on all of this. You can't discern a rate. It's rapid and unorganized. It's not a regular rhythm at all. There's no P wave, there's no PRI, and you can't differentiate a QRS. So this is an example of ventricular fibrillation that is fine. You've got a very low amplitude fibrillatory wave, but you do have a fibrillatory wave, so defibrillation immediately is called for. And then you've also got coarse ventricular fibrillation. Not to be confused with torsades, which is what this is, but this is completely chaotic and unorganized. Asystole, it refers to the complete absence of any electrical activity and is electrocardiographically represented as a straight line or almost straight line. It is just baseline with no waveforms moving up and down. Like VFib, asystole does not produce a palpable pulse. However, there is no electrical activity going on at all, so defibrillation is contraindicated in this situation. You do not shock asystole. Again, the answer is no to all of these questions. So this is an example of ventricular asystole or cardiac standstill. An agonal rhythm is a variant term for asystole that's sometimes used by clinicians during daily practice. Essentially, if you have what you think is a idioventricular rhythm, but the rate is less than 20, it is considered an agonal rhythm. And honestly, it's just as good as asystole, meaning it's not good at all. And pulseless electrical activity. So this is also on the algorithm as well, and essentially pulseless electrical activity is formally termed electromechanical dissociation. And remember, you've got an electrical aspect of the heart and a mechanical aspect, and they have to work together in order to create a cardiac contraction. With pulseless electrical activity, there is a disassociation between that. There's no mechanical activity, there's only electrical activity. And so you're not getting any type of cardiac output. So it could be any type of rhythm on the monitor, but if you don't have a palpable pulse, then the patient is in pulseless electrical activity. And PEA, so this is where we have to remember our H's and T's on our cardiac algorithm. So here's an example of coarse ventricular fibrillation. Coarse ventricular fibrillation. This is very fine ventricular fibrillation, not to be confused with asystole. You have an agonal rhythm, always look in multiple leads, and then you see asystole here. So if there's no cardiac output or no perfusion, you need to start CPR immediately. If you've got fine VFib, go ahead and shock the patient. CPR defibrillation, airway management, IV medications, epinephrine and amiodarone or lidocaine. Asystole signals a complete termination of ventricular activity, so make sure you check in 2 leads to rule out the presence of fine VFib. CPR, airway management, including an advanced airway, and pharmacological intervention, which includes epinephrine and IV fluids. You do not shock asystole, but you do need to think about your reversible causes, which are your H's and T's. So looking at this algorithm, the cardiac arrest algorithm, if we note that this patient is pulseless and apneic, we need to start CPR immediately. Starting CPR includes chest compressions at 30 to 2 and also bagging. If you're by yourself, compressions are most important. Then we need to put them on a monitor. Are they in a ventricular fibrillation or ventricular tachycardia without a pulse? Then immediately shock. Don't wait your full round of 2 minutes. Go ahead and shock. Then we continue with CPR for 2 minutes. Then we check, is the rhythm shockable? If it is, we shock. Then we continue CPR for 2 minutes. While we're doing CPR, we go ahead and give epinephrine 1 milligram of a 1 to 10,000 solution. Then we consider advanced airway. After 2 more minutes, we check, is the rhythm shockable? We will shock. Then we start CPR back. At this time, we'll give another round of epinephrine if it's within the 3 to 5 minute time frame. And then we also consider amiodarone. Amiodarone would be 300 milligrams initially, followed by 150 milligrams, or lidocaine. We don't give both. We only give one or the other. Our lidocaine dosage initially is 1 to 1.5 milligrams per kilogram, followed by a subsequent dose of 0.5 to 0.75 milligrams. Moving back up, if our patient's not in a shockable rhythm, they're in asystole or PEA, early epinephrine and early CPR are both indicated. CPR first and give epinephrine as soon as possible. Again, epinephrine's 1 milligram of a 1 to 10,000 solution given every 3 to 5 minutes. This algorithm is essentially CPR for 2 minutes, check rhythm, epinephrine, CPR, epi, consider advanced airway, get an advanced airway, put end-tidal CO2 on, and then consider your reversible causes, which include hypovolemia, hypoxemia, your hydrogen ion, which is acidosis, hypo or hyperkalemia, or increased or decreased potassium levels, hypothermia, tension pneumothorax, cardiac tamponade, toxins, thrombosis pulmonary, or thrombosis coronary.